our speaker, Cameron McDermott, who's an epidemiologist with Ottawa Public Health, with an interest in syndromic surveillance, environmental health, and the social determinants of health. Cameron has been involved in the syndromic surveillance system that we have in Ottawa, known as the Asset Project, and he's one of the primary users of the system. And today he will talk about his experiences with that system and how it's being applied at OPH. So with that, I'll pass it on to Cameron.
Thanks very much, Khaled, and welcome to all of you. I'm in a room with a Polycom right now, so you may be hearing a little bit of an echo. As well as we progress through the slides, there may be a little bit of a lag, so I may be pausing at times, allowing your displays to catch up. My contact information is on the front of this first slide and will be in the slide deck. So if we're not able to get to your questions in the session today, please do feel free to contact me and I'll do the best I can to respond. As Khaled mentioned, I'm involved in the asset system or the syndromic surveillance system here in Ottawa. My involvement there began in December of 2008 and has progressed since then. At that point, the syndromic surveillance system, the construct and the integration of it into the hospital system was pretty much completed and was just getting rolled out. So a lot of my involvement is more in terms of the post-implementation phase. So I'll be talking predominantly about that, some of our experiences and challenges around that, and some of the work we really have yet to do. The hope is by sharing some of these things that you'll be able to think in much more of a bigger picture about whether syndromic surveillance is something you would want to entertain if you're not already, or benefit from some of our experiences here, or even just establish that dialogue. So before we start, Khaled had sent me a list of the attendees, and I saw some familiar names on there, but I'm not sure how much everybody has in terms of a background in terms of syndromic surveillance. So what I'm going to start off with is just try to put everybody on the same page, and that will provide a framework as we progress through in terms of what we're going to talk about today. So you can read this definition as well as I can read it to you, so I'm just going to let you go ahead and do that. But the idea of surveillance having specific components, more specifically an ongoing and systematic collection that involves an interpretation and analysis explicitly. And from my perspective as a public health epidemiologist, the use of that information is what's really critical. And we'll be talking about some of that as we go through today, and that's predominantly what I'll be discussing. But really, when we talk about surveillance, it has to contain all of those three components. And while some may be more interesting than others for certain people, for me as an epidemiologist, the use of it is really what's critical. So a syndrome, the sum of symptoms and signs of any morbid state. If you're involved in clinical medicine, this isn't something new to you. And an important point is it doesn't necessarily require a confirmed diagnosis. And I put confirmed here in quotes because oftentimes when people think of disease states, they think of absolutes. So something meets a specific case definition, for example, that would have a positive lab test on some parameter or something really well and tightly defined. Syndromes are that to an extent, but are sometimes a little more amorphous in that they are real just collections of symptoms and signs that may be coming up and describing somebody's health state. Arthritic conditions, for example, oftentimes there is no one single lab test, for example, that can determine whether somebody has rheumatoid arthritis, for example. So it's important to remember this, though, when we're talking about how we use the data and who's using the data, more importantly. For us as epidemiologists who may be entrenched in the use of syndromic surveillance, we may be fairly comfortable with this idea of a syndrome, but it's something you have to keep in mind when we're disseminating the information that may arise from the system. So putting the two together, what we're trying to do is infer disease from patterns and syndromes in existing data streams. There's lots of data streams that are available, and I'll talk a little bit about that in a minute or so. And there's some sort of case classification or processing that happens to those records in order for us to make sense of this from a syndrome standpoint. There's also some evaluation that happens, and as I mentioned in the previous slide, there's some use that information is put to. So why would we do something like this? Well, if we consider a specific exposure, and although this looks like an explosion, it could be pretty much anything, whether it be a re-emerging disease, a disease that you normally see in a particular season, or anything really. what we have is a development of a syndrome where people express symptoms and signs that may arise from that exposure over a course of time. There's also a diagnosed illness that may arise from that as well, depending whether these people seek care and what processes are in place to diagnose the disease. For public health, particularly, notifiable disease reporting may be your first interface with the diagnosed disease unless somebody goes outside of the normal reporting loop and contacts you. And there are certain diseases for which that is the case. But in general, those things are all framed inside a notifiable disease reporting framework. So there is an inherent lag from the syndrome presentation, the signs and symptoms, to diagnosis, and then on again to the actual reporting of that disease. So this is where syndromic surveillance is intended to take place. And the whole point here is to try to approximate these two peaks so that your awareness of the disease is much less reliant on the existing diagnosis reporting framework. So there's lots of things that can affect the size of this gap. For example, if you have a novel disease for which there is no established diagnosis test, this time frame may be quite a bit larger than it appears here. But in general, what we're trying to do is exploit the syndromic surveillance system so that we don't have this time lag between when people are getting sick in the community and when we actually find out about it through an existing framework. So I'm going to use an example here to illustrate how this would work in real life, and this is a project that was done in the Great Bruce area with a number of different participants. I wasn't involved in this project, but I'm going to show you some of the results from their work. So as background data, and this is a busy slide, but I'll walk you through it quickly. This is with regards to Walkerton, and for those of you who aren't from Ontario or from Canada, Walkerton was an example of E. coli that was in the water system and caused a fair bit of disease in the Walkerton area of Ontario. And this is sort of how it rolled out in terms of notification. So there was a call on a Friday, there was faxes sent out. You can sort of follow your way through here. There was presumptive E. coli results. E. coli was confirmed on the Sunday, and there was some contacts where exposures were looked for, and by Tuesday of the following week, there had been water samples that were positive for E. coli, and the notification sort of rolled out from there. So that's sort of what happened in a very broad strokes. So the question was, we've got this instance we've seen in Ontario. How would a syndromic surveillance system have responded to this? Fortunately, events like this are fairly rare, so the actual test of a syndromic surveillance system isn't something you can do routinely. So this retrospective analysis was done. So what I'm going to do is walk through some slides here, and what you'll see here is that the bigger the dot, the greater number of emergency room visits, which were classified by the system as being GI. So they were put into this garbage bag we call syndromic, a GI syndrome. The redder the dot, the higher the proportion of cases, because an increased number of cases may be due to more disease in the community or just an overall increase in attendance at the ER overall. So this may lag a little bit as we go through, but essentially what you'll see is an increase around Walkerton that progresses over the course of the following week. So if we look at that in terms of what records are available, this is the total number of ER visits to the 10 Grey Bruce area hospitals, which are around the Walkerton area. Looking at that, you don't really have a good sense that there might be something unusual happening. If, however, we take the classified GI syndrome cases, we can see that there's something more abrupt occurring, and if we blow that up a bit, this is a much more useful pattern in terms of detection. You're seeing a very marked spike relative to the background that you're seeing elsewhere. If we look at the Walkerton ER visits, that expression is there, so we're drilling down to a micro level now and just looking at a specific health center. And again, we still see the same syndromic pattern at that one hospital. So in terms of timelines, would this have done anything different? This is an example of the symptom onset for the cases in the instance, as well as the ER visits were classified as GI. Now, while it may look at the top that the symptom onsets preceded the boil water advisor and preceded the visits to ER, that only makes sense. What we're looking for in the ER visits is an increase in the slope here as the cases accrue. The algorithms will be looking at new cases being above an expected value and firing off an alert in that case. So the conclusion of the group was that the syndromic surveillance system was highly sensitive to the outbreak of this kind, and it would definitely have either confirmed the physician's concerns on the Friday and would likely have detected a GI outbreak in Walkerton had the physician not called. Now, this is a retrospective analysis, and it really focuses on the first part of what I was talking about with regards to syndromic surveillance, which is the detection and analysis. If we go back to this line, or this graph, pardon me, what we're really looking again is exploiting that time gap. Now, detection is one thing and action is another. So my interest in this system and my participation in it thus far has been really focused a lot around what is the response to the information you get from your system. What do you do? Who do you tell? And those sorts of things. In the previous study that I just described in Walkerton, the detection piece seems to be working, but that's not really that valuable unless you have a system response to that information that can exploit that time gap. So the choices of surveillance points also make a difference, and there's lots of different ones. I've just drawn a continuum here to express a few of them. Information seeking, some people may have seen the Google Trends system, and where you insert a search term and it will give you searches that people have done on the Google system. ISIC, which I'll provide a link for later, has predefined search terms that can help with certain syndromes. Self-care, over-the-counter antiviral reports, or in Ontario, telehealth information where people are calling a helpline to get information about self-care. At a primary contact point, you've got electronic medical records or sentinel physician systems that may be set up. And at more extremity of care seeking, when you're in emergency rooms, you may have screening data where people are attending emergency rooms, or you may actually have data feeds that relate to the ER visits themselves. All these information points have pros and cons. One might be granularity. If you've got a very local event, will some of these information-seeking pathways really give you the information you need? You also have questions about timeliness and access. Are these information systems in place such that you can actually access them in a timely way to exploit that time gap? So these are all questions that can be asked. Our information system relies on the data feeds from the emergency rooms, and we'll talk a little bit more specifically about how that rolls out. But the bottom line in terms of exploiting that advantage is that you have to have confidence that what you're seeing is relevant to you, so that it is in fact reflecting an increase in disease activity of interest, as well as that you have a protocol in place that allows you to act on what you're seeing in a meaningful way. So the asset system, and Khaled mentioned this right at the outset, so everybody likes their acronyms, and we're no exception. So the Advanced Syndromic Surveillance and Emergency Triage System is what ASSET stands for. Version 1 is the implementation right now. It's based on ROD's version 3, which is an open source syndromic surveillance system. And I've provided links to the back of the presentation for all the stuff where I'm referring to things that I'm not discussing internally. There's been a number of patches that were applied to that from the earlier production versions, as well as other people's input on the syndromic surveillance system. So it's not a vanilla version by any stretch. These are the different partners and collaborators in the ASSET program, and there's, again, a lot of people have made a lot of contributions to making this what it is now. So in general, what we're talking about when we talk about ASSET in Ottawa, we're talking about currently 4 hospitals providing data. We've got a 5th one that's poised to come online. Data is categorized and analyzed every 6 hours. All the data is housed off-site at the Ottawa hospital system. There's an email alert if the number of cases is higher than what we would expect to see. And our system is monitored each day by the OPH epidemiologists. Now, I'm going to break this down a little bit. This is sort of just to give you a rough orientation of the system in terms of how it does detection and how we would do analysis. But in general, this is how the system works in a big picture. So we've got everything that you see here in blue is essentially what's housed at the Ottawa hospital system. We've got HLL 7 feeds that are processed and counted, and I'll talk a little bit more about how that's done. Data storage is all remote as well. There's mapping and user interface processes that happen via a web server. And you can see on point 4 on the graph, there's a loop out where the outbreak detection and alarm notification sends an email to the end user. And that's me that you see that down there in your bottom right. I have access to this system by going through it through the Apache web server system through a web interface, and I also am connected to the system by virtue of the emails that it sends to me. So this is the data that we have access to in Ottawa. We've got a sequential case ID that's assigned by the system. This isn't related to the person's client ID, hospital number, or anything like that. It's just a way to keep track of people in the system. We've got admission dates. We've got the sex and age of the case. We've got a 5-digit postal code, symptom and chief complaint, and then the syndrome that that person is assigned to. Now, the asset system, and something that's a little unique about it, is that people can be assigned to multiple syndromes. If you think about it, these symptoms are not mutually exclusive of a number of the different syndromes, which I'll show you in a second. So what we were really hoping to get out of the system was recognizing the fact that people could belong in more than one category. Not all our hospital sources provide the last 2 information points, which is final diagnosis or the triage code. So it's a 5-point scale that gives you some idea of the severity of the person's condition. We don't get those from all sources, unfortunately, and that's something we've had to deal with in terms of the analysis and reporting, where not all the information we get may be the same from hospital to hospital. So the cases are categorized into the syndromes using chief complaint, and I've laid out a few here that may raise your eyebrows a wee bit, but part of the thought is that the background of the system, you're really constrained by what the system is actually providing you. In a system that provides free text, for example, you may be getting something that doesn't really fit into a neat and nifty category. Some of the hospitals are using what are called CDIS codes, which is an Emergency Department Information System code. There's, I believe, about 161 discrete codes, so that's what's used to code people's symptoms. So the data is a lot less granular and perhaps a lot less sensitive than free text would be, but you also don't have as many interpretive points as free text might provide. So what happens in the asset system is that there is a case classifier that was developed by the National Research Council of Canada. This system is actually trained by an expert classifying symptoms using sample data from the actual hospitals that you are monitoring. That classifier can be retrained if you're finding problems with the classification, and it can also learn new things. If you, for example, add a syndrome, which is something that we can do by adding a user-defined syndrome, what it allows you to do is retrain that system, which allows a very regional approach. The advantage of that is you're not stuck using a standardized template that may regionally not be as representative as you would like. For example, if there's different diseases that may be in your locale or different ways the physicians in the ER talk about it or the way this information is recorded, you're not relying on a standardized template. You're relying on a system that's classified using exactly that data. So essentially what the system is trying to do is emulate that expert in terms of classification into one of the various syndromes that are available, or in this case, multiple syndromes in the asset system. These are the standardized syndromes that are available in asset, pardon me. Some of them aren't mutually exclusive. For example, asthma is a subset of respiratory. Influenza-like illness, constitutional, may have some commonalities. And I can provide a list of the actual definitions of this, which I didn't include here because it would take up a little bit too much time. But in general, you have a number of different ones. Some of them may look a little curious. The botulinic one, for example, pardon me, somebody's stuck in an auto advance. But when you think about where this system arose from, a lot of it arose from an early warning system for bioterrorism attacks. So things like a botulinic syndrome or neurological problems make sense. Fortunately, those aren't things we see very often in the system. The alert algorithms, there's 2 recursively square system that is based on the past 120 days of data. There's a QSUM that's based on the last 14 days of data. I'm not going to discuss the algorithms too much. The alert system we get is in excess of 3 standard deviations over what's predicted. The system is set up so that no alert will occur if the case count is less than 5. The problem with low case counts is that it doesn't take very many cases in order to trigger an alert if you're under 5, and we found that it was just a little too sensitive at that case. So we've sort of decided to set it at 5 cases. All this stuff is modifiable within the asset system, and the alerts will go out in one of these 4 time intervals. So there's essentially 4 time intervals over the course of a 24-hour period where the alert could fire. You will only get 1 alert in any 24-hour period. So if I get one at 12:15 on a day, I won't be getting subsequent ones at the other times within a 24-hour period. This is one of our first stabs at looking at a response algorithm and trying to figure out how do we deal with this stuff as it comes out of asset. So looking on your left-hand side, we've started off with describing the alert and then providing it some context, potentially doing some case-based analysis on it and some internal consultation before some specific action might be required. Now this is a rough frame and may modify a little bit, although it's nice and compartmentalized here in practice. It probably flows more than it shows here, where different aspects of it may be combined. And it may not involve a particularly large pause between any of these things. Since we've developed this, a lot of the contextualization and description of the alert have been much more standardized and automated, so that some of these steps take a very brief amount of time in order to implement. On the right-hand side, some putative things that may increase or decrease your concern about a specific alert. I mentioned right at the outset that one of the important aspects of the alert system is that it makes some sense and gives you some information about what you're really worried about, which is an increase in disease that would be a public health concern particularly. So essentially what we're talking about in that case is an external validity. The alerts are firing off based on an algorithm, so they have some internal consistency where hopefully you're not seeing a lot of variation within the system in terms of the information that would be presented to it and the output of an alert. The piece of this is does the alert really mean anything? And we'll talk a little bit about some concrete examples in a bit, but the idea that an alert, again, going back to the onset of the presentation, when we're talking about syndrome as a collection of symptoms, just because we're getting a GI alert doesn't mean that all the diseases are explicitly infectious disease-related GI complaints, which would be available in a final diagnosis. If you've got abdominal pain from an infectious disease, that's put into the same syndrome as if I punched you in the stomach and you have abdominal pain. So you're constrained a little bit by how the symptoms are processed, and it's important to remember that piece as you go through. Even though the alert's occurring, with what external validity does it actually represent something in the community that would be of concern? And I'll talk a little bit about some of the things that we've come up with. This map is an attempt to try to deal with some of that. So a large case excess versus a low case excess, for example. So when we look at the number of cases that are comprising the alert, if we're seeing very large volumes and very rapidly, that would be something of concern. If you think back to the example of the graph from Walkerton, for example, with GI complaints, there's a very rapid accrual of cases. A high triage acuity for those hospitals that we have the data for might be of concern. If we're seeing final diagnoses, then if there's something that's expressed explicitly there, that would be of concerns. And essentially, as you look down through this list here, you may see things that tweak you to say, okay, that would be something that I would really worry about. If you're seeing multiple hospitals involved, if the alerts are maintained over the course of time, if there's any sort of clustering that may suggest a point exposure or infectious disease process, those are all things that may raise concern. Now, part of the problem with this kind of model is that there's really no way to test it easily. So even though we say, oh, if multiple hospitals are involved, that would increase our concern, we don't really know if that contributes to the external validity of the alerts yet, because we really haven't had problems run down through the production system to express that. But these things make some inherent sense, and so they've got some face validity. Other things on the right-hand side, when we're looking at alerts that may be consistent with expected seasonal patterns or historical trends, that requires historical data, obviously. And the system's been running for about close on 3 years or a little bit more now, with the multiple syndrome reporting less time. So we're still looking at how do we make sense of some of the historical trends in the data we have. So what is that response? I've talked a little bit about what's happening, but when the alert comes down the pipe, it's received by one of us and we access the system versus a two-step security portal. This is what an alert actually looks like, and this is an early version. It's changed a wee bit, but in general what you're provided with is an observed syndrome count and a threshold syndrome count, and gives you some information about why the alert occurred. Now, these are syndrome counts, and they're not daily counts, they're not counts by day, so they're very difficult to sort of wrap your head around to see whether this is important or not. And part of this is very much a gut feel after having been exposed to these a bit. Once you go into the asset system, you're provided with a couple of graphs as well as the line data for the cases that are contributing to the alert. This is one interface we have. We also have others, which I'll talk about in a second. But this gives us our first sort of insight into what's happening. So in the example of a botulinum alert, for example, we may see particular final diagnoses that may arrive. So oftentimes the symptoms for a botulinum alert will be things like diplopia or difficulty with vision. So those things all help us figure out whether this is something of concern just in a very quick glance. The graphs aren't all that useful because the total visit graph that you see on the left, for example, is actually the total number of syndromes, not the total number of clients. And that was a bit of a challenge once we introduced the multiple syndrome process. And it just looked like it was going to be too burdensome to go back in and retweak how all the graphs are done. And primarily we do most of our graphing externally in an off-the-shelf stats program. It gives you a little bit more flexibility in terms of the kinds of things you can plot, and it also gives you, by and large, better graphing quality output if you're making reports. So this is our first pass through. Once we've got the alerts, how do we describe them? And this is the software we use is Stata, but you can use any off-the-shelf stats package really. This is information that's pulled from a 30-day download. So we get a data set that includes all the cases for the last 30 days, for example, or we can use ones that are just particular for the alert. In this case, what we're looking at is an Ottawa-wide alert with 4 hospitals contributing. It gives you some idea of which hospitals are contributing and in what proportion, patient proportions by sex, and proportion of cases by age category. All this stuff is customizable because it's done in the stats program externally. There is some capacity within Asset to do exports or show graphs based on some of these parameters, but as I said, oftentimes it's just faster to go right to the data and run a script against it, which is what we do here. Frequency of symptoms. Now here's one of the challenges we've come up with and some of the processes that we're working to solve. A lot of these are very similar. So if I ask you very quickly how many people have nausea or vomiting, you can see that even with the coding system in place and even with CDIS coding, there are some things that group together that aren't being grouped. So we're working on a process to improve this a little bit as well, external to the asset system. You can describe the alert by showing graphically what's happening. So these are the 4 reporting hospitals with ILI syndrome over the last 2 or 3 weeks now. The vertical bars you see are alerts, so that you can see in this instance Hospital 1 had a successive number of alerts firing off, whereas Hospital 3 had one in around the last weeks in January. So this gives you some sort of big picture context and idea of how do you describe the alert in terms of the context of what's happening at other hospitals, both with regards to the total number of cases. In this case, we're seeing proportion of cases rather than raw counts. What's happening at other hospitals and what's happening historically with the alert system. It's a very quick glance that you can use to sort of figure out what's happening or what has happened. And as I showed you in the slide that described the response protocol framework, historical or continuing alerts may be of more concern. So the context for the alerts is also through a number of different media. So either a direct communication with an emergency room, phoning them up and saying, are you seeing what we're seeing? You may have other systems that are in place with either various levels of frequency of reporting or systems that you can quickly access. So here we've got schools, child care, long-term care facilities are all required to report their outbreaks. There can be some lags in that, or there can be some process pieces about how often these things are updated. But it gives us a fairly quick overview of what's happening at the community level. For example, when we're looking at those ILI alerts on the previous page, we're also looking around to see what's happening in long-term care facilities. Are there influenza-related outbreaks, for example? And in this case, there were. So we've got some external validity that what we're seeing is not a glitch. It is representative of what may be happening in the community. Febrile respiratory illness screening that may be happening in hospital settings is another one. We don't routinely get that data. During the pandemic H1N1 outbreak we did, and we found that there was some pretty good parity with regards to the various flows, although the criteria for inclusion in what would be a respiratory syndrome is slightly different between the two, but they weren't hugely discordant. And we haven't done a detailed analysis to see how predictive the alerts would have been in terms of increased hospital flow, but that's something we're going to be working on. In Ontario as well, the telehealth system that I mentioned earlier on gets information from people calling in and asking about self-care with relating to different complaints. We also have adjacent health units. The Kingston Health Unit KFLA, which is right next to us, is involved in a Quest project, and I've got some links at the end of this slide, which is a syndromic surveillance system that slightly different from ours, but by and large same principles. And their reporting system and especially to the public, is much more mature than ours, so we've got some catching up to do, but I've included some links a little further on so you can have a look at that for yourself. So, for example, this would be an example of screening data. 5 different hospitals reporting screening data in the 2009-2010 influenza season to date, which you can see from the graphs. This is a proportion of ER clients here rather than counts, so you can see this curve of accounts. What we'd be looking for is to see where does the asset system overlie with this to try to give us some idea of the relative timing of the two. This is an example of a telehealth alert that we may get. So the fever ILI syndrome call cluster in Ottawa, for example, in the first week in February, we're seeing a number of different calls there. Part of the issue too, when you're looking at these different sources, is does this relate to the alert system that I just saw? So if we go back to this graph here, end of January, early February, into February, we're seeing alerts. We come back here, this is more or less the same time frame. We may have a couple of days advantage over the telehealth alert. And the telehealth alerts are actually fairly rapid. The dissemination is fairly close after the time frame date you're seeing here. So the question is, are these two related, or is this representative of something else, or something we have yet to see in the asset system? It's something that's always niggling in the back of your mind. But in this case, they seem to be talking pretty much about the same thing. So we've got some concurrent validity from externally to show that people are calling. And if people are calling and we're getting ER alerts, this system, when you think back to the very early slide about where the different places you can pull syndromic surveillance out in terms of a course of care, so information about care, self-care, primary contact care, and then hospitalization. Hospitalization is the last step as people get sicker and sicker, dependent obviously in terms of the course of the disease. But here we're seeing an ER system that at least matched and maybe was a little faster in letting us know something was going on in the community before we got this system. So we don't have a lot of these things, so it's very difficult to make sort of sweeping conclusions about that. But at the very worst, they're concurrent, and so we're fairly confident what we're seeing is representative of something that's happening in the community, and not just, like I say, a system glitch. The dissemination piece, I mentioned KFLA public health regions, much more mature than we are. This is still a work in progress. We're looking at internal reporting for planning of responses, for example. So an example may be an opening of a flu center or preparing a public service announcement. The external reporting as well is another piece. How do we communicate back to the partners that are participating in this, vis-a-vis the hospitals? And also, how do we communicate to the public and other healthcare practitioners to give them meaningful information that can inform decisions? So we've had meetings around these different topics with the emergency room physicians who are still in the pipe. We've been talking with infection control practitioners in hospitals. Their question is, what does this do for us? And that's not a question we could necessarily answer until we get something rolling. And we've got some draft versions out to them to try to help them see if this is information that's useful. There's also the concern aspect that may be expressed here. We're not just necessarily talking about a universal benefit and everybody's really happy. One of their questions back to us is, would this increase in appropriate testing? If physicians are aware of something going on in the community, are they more likely to order tests that may be inappropriate? Now, I can't speak to that issue, obviously, and we haven't met with the ER physicians yet, but it's something to keep in the back of your mind that not all the information dissemination may be benign. One of the critiques of syndromic surveillance is that it muddies the water and doesn't give you a lot of more additional information in what sort of meaning do you take away from it. So we're still in a step-by-step process to try to define that. Locally, it seems to be very useful, and I'll give you some examples of that in a moment. I'll give you one right now, actually. So in early 2010, we got an alert on January 5th for the GI syndrome. The alert was sustained. When we're contextualizing that particular alert, we knew that norovirus was known to be in the community. The direct contact with the local hospitals identified that were seeing an increased number of GI, and patients that were diagnosed with small round virus were confirmed at 1. So essentially we're seeing that this is contextual, this is something that's going on. We're seeing increased number of volumes going into the hospital. So public service announcement was broadcast in the Ottawa area, letting people know that we were seeing this, reinforcing some of the public health interventions that would hopefully prevent some of this, hand washing, that sort of thing. So the system provided a very quick input in the system. Then in a matter of a course of a couple of days, once this had been confirmed and the alerts were sustained, the public service announcement was sent. Subsequent to about 2 days after we sent the public service announcement out, we got a call from another local hospital saying, can you please send out a public service announcement because we're seeing all this stuff. So that was some validation for us that the intervention preceded what may have been requested by some of our partners in the field. And following that, we got a telehealth alert saying that there was an increased number of GI-related calls in the area. Now, at this time, the telehealth alerts were delayed somewhat, so under the current system, we probably would have got that a little sooner. But again, it's some validation that even in the absence of a real cataclysmic disease like what was seen at Walkerton with a really rapid accrual of cases, the syndromic surveillance system seems to be playing out and allowing us to make a public health intervention in a meaningful way. Now, that may seem sort of banal related to a boil water advisory or something more exciting in terms of an outbreak investigation, but the system is running all the time, and you still have to make sense of these alerts as they come in and make a decision about under what threshold would you actually act and intervene. This is another example. This is a retrospective analysis with some of our respiratory alerts that were happening in and around early 2009. The peak you see on your left on the top of the cave plot that shows alerts happening in and around the beginning of September, we've found is actually a historical norm. We tend to see these things right after the schools go back into session. We've also been able to validate that with some of our hospitals anecdotally saying, is this something you routinely see? And they've validated that as well. So that's an important historical piece for us, that we're not panicking when we're seeing these things happen in early September, but we're also poised to look for the other things that I mentioned, whether the alert is sustained, whether we're seeing unusually high levels of acuity or diagnoses that are of public health concern. So in this process, this seems to validate, even in a normal flu season, that the system is working. We also saw a flurry of alerts towards what we expected would be the end of the flu season, which of course was the incoming pandemic H1N1 case. Now in this case, we were already poised and ready for a pandemic H1 to come down the pipe. The question we had is it here yet? And the asset alert system seems to have been pretty good at giving us a bit of an early warning of when that's coming down the pipe. These are some examples from the Grey Bruce area that I mentioned earlier with the ECAD system. So they've done a number of different things. They've had the system a little longer, but characterization of outbreaks. The other important piece here is they're looking for illness when there may be no evidence of it. So essentially, if you've got a water filtration plant problem, or you've got a detection of E. coli contaminated strawberries, you're looking at the system to see if it is going to alert. So not necessarily passively waiting for it to happen, but actively monitoring it to see what might be going on with the different syndromes. So that brings up another important point that I didn't mention earlier. The benefit here is not necessarily just the alerting system, but also the situational awareness a system like this can give you in terms of what's happening. So the next steps that we have in terms of looking at the response protocols I discussed is testing some of them. How long do they take to happen? How can we implement this stuff in a meaningful way so that the response isn't in excess or that we should have acted sooner? We're still working on how we're going to do all that stuff. I mentioned the ongoing consultation with partners, and really the questions are pretty basic. What would it help and what would it look like in order for you to either know what's going on or be able to make decisions about what you might need to do in terms of your normal operations, given that this may be an alert that has some legs and there may be something coming down the pipe you need to know about it. What we found in this consultation is different partners and even different hospitals have very different needs. We've had some hospitals say that they're really not all that keen on getting anything too detailed, and certainly not on an ongoing basis. They may prefer us just to call them. We've had other hospitals say we would really like this information because we feel really isolated and we really don't have a sense of what's happening in the rest of Ottawa or at the other hospitals, and we think this would be really valuable information. So we're still looking at tailoring different products for the different players, both internally and externally. Mapping, which is something KFLA has done very well, we're still working on. We're working on mapping based on the 5-digit postal code, and I can show you a quick screenshot of that in a second. So this is something that we're just developing and, again, looking to see what does it really tell you. Obviously, with mapping cases on a very small or a very granular area or granular basis, you run the risk of a type 1 error when you're seeing these things pop up if you're continually scanning the entirety of Ottawa. But it does give you, if you take a step back, it does give you some idea of what may be happening regionally within the system, and we're still looking at that. So a more formalized analysis of concurrent validity. I've talked a little bit about how we've got some indications that the system is running. We've got a master's student that will be working around issues of seasonality and a few other things. I think she's on the line in the next little bit. So we've got some work that's going on, and like most people who are in public health practice, it would be great to be able to do this stuff full time, but unfortunately that's not the reality. So we're chipping away at this as best we can. The better parsing out of symptoms, we've had some discussions with the National Research Council folks again on this one, and we're still working towards a solution to try to get a better idea of whether we can compartmentalize the symptoms, either with respect to some of the differences in how they're expressed in the system, or alternatively perhaps looking for ones that may be of great concern. So something that might be a bell ringer, for example, where we see a particular final diagnosis or particular cluster of symptoms or specific combination of symptoms, age or whatever, to sort of flag us that there might be something buried within the syndrome bucket itself that may be of concern. So this is an example of a screenshot of the total count by 5-digit postal code. One of the challenges we've had here is that depending on the data, we suspect that some of the people who are attending hospital may have the hospital's 5-digit postal code and not their own. So we're still looking at validating that. But it gives you some big picture idea of what might be happening with distribution across the city of Ottawa. The other things we have to do here, obviously, if we're using 5-digit postal code, is control for populations and that. And again, that's a process we're doing right now. We're just for now looking at total counts overall. So thanks for your attention. I've got a few of the sites or references that I talked about here in a link that you can go and have a look at if you're so inclined. There's probably some other ones that I mentioned that don't appear in this list, so please feel free to email me. And that concludes the presentation. I don't see any questions. Is that right, Khaled? Or
so
I guess we're opening it up for questions now.
Yeah, so you can type in your questions now, and then Cameron will be able to pick them up. So while folks are typing, I actually had one question to get us started. Do you have any information, Cameron, on the accuracy of the classifier?
A lot of that work was done prior to my involvement, but there was, and I don't have it at my fingertips, but the classifier accuracy has been tested and is quite robust. And it's been compared against the COCO system, which was the system in RODS itself.
Okay. Okay, questions are coming in. Can you see them?
I can see them, yes, and I'll speak to Denise's question first. The slides will be made available to participants, and Kelly had mentioned that at the outset. So, or if you prefer, if you need them before they're available, you can always contact me. So Jim Daniel, talk about the PSAs. Well, the PSAs were done that have been done thus far primarily around GI disease and then reinforcement of influenza-like illness. Behaviors related to reducing transmission. So don't go to work when you're feeling sick. Sneeze in your sleeve. Wash your hands. That sort of thing. So they're fairly routine things that we do anyway. It's just a question of when you do it and when a particular topic may need a bit more of a shove to get it through. So in the example of the GI complaints, we don't routinely do PSAs around GI, more so around things like influenza. But it was thought that in this case, because we were seeing increased numbers of activity, it would be not a bad idea to push it out there. And the example I gave of the hospital calling, a lot of that, their request for PSA was to offload some of the emergency department volume when they have people care seeking at an ER level when they maybe shouldn't be, but also that we would be able to try to stem the number of people maybe getting sick by giving them some information up front. So now let's see here. I just have to scroll through the way the system is running. I'm seeing part of it, so I may actually, I can just click on the question here. Hang on. I just want to sort of stay in as good an order as I can. So the question from Michael was with regards to comparing different years and answering the question we get, how bad is it this year? Which is a very common question. We're still building that data set, and we haven't done that extensively at this point. Part of the issue, too, is that when we moved to multiple syndromes, the system did get reclassified, but we didn't get alerts going back, I don't believe, using that multiple classification. So there's been a few changes in the system. So that's something we're going to look at to see how bad the number of alerts are, but there's something that's changed in the way the alerts are delivered in the system itself. So we have to keep that in mind as we do it. The other question, I guess, is whether or not the question is really how many alerts do we get, or things like how many people are going to emergency room and how many people are providing drains in the system. We do have that information. So we're probably looking at a combination of factors, but we haven't done it yet to go back and say, okay, this year or this particular season or these number of months had X number of alerts. That means it's bad. Because again, we have to validate every alert as being externally valid or not. So the instance, for example, of botulinum syndrome, we have to be aware that we rarely see them, and when we do, the case excesses are a matter of 2 or 3 cases because the case counts are so low. A low number of cases will trigger off the system if you get even a few more cases added in. The other piece about whether or not there's other things going on that may explain the alerts. So when you're answering the question, how bad is it how bad beyond what we would expect to see given some of the seasonal variations, and I showed you the example of the one in the respiratory syndrome. So short answer to that sort of lengthy responses is something we're still working on. Okay. So I'm just going to scroll up, and I hope I don't miss anybody here. 5-character postal code, we weren't allowed to go down to 6. The hospitals pushed back about that, so we went to the next level up that we could, which was 5. In the mapping, we're looking at in terms of how we use that information. Again, we're starting off with 5-digit postal code mapping. That may be way too granular to give us some good information if there's lots of week-by-week variations, which is sort of how we're looking at the maps thus far. We're looking at the maps more as a descriptor of what's happening rather than an actual detection system in and of itself. And we may find ultimately that we have to go up to FSA, that is the first 3 digits of a postal code, or doing something completely different. There are other geographic frameworks that we can map this data to. For example, wards would be an example at a local level. In Ottawa, we also have neighborhood mapping from postal code to neighborhoods. So there may be some other geographic frameworks that actually make more sense than what we're using. It's just the place we've started based on the data we had immediately available. And here's the question about time spent monitoring, which is a really good question. In the course of a normal day, for example today, it might take me 20 minutes to generate a report and distribute it. And that report would include a notification of alert, provision of context of alerts, as well as a case analysis of the people who have comprised the alert. So if you think back to the steps, we're talking about the first 2 steps, providing some context as well, so looking to see if there's been a telehealth alert, seeing what's happening in adjacent health regions through KFLA's Infection Watch online mapping system. So all in all, it takes about 20 minutes. If it requires a big drill down, or I need to start parsing out cases based on something that's not scripted, it takes proportionally longer to do that. But most of the stuff is scripted, so we can get through pretty quickly.
Cam, I just had a comment here. Can you repeat the questions, because not everybody can see them?
Oh, yeah, no, sorry. So the question I just answered is what's the rationale between a 5-character postal code versus something else? So I apologize for that. I've done that for a couple, but haven't done at all. And the last question was about how much time is spent on monitoring and reporting syndromic surveillance data each day. So the monitoring is a matter of looking in the mailbox and seeing if the reports or the things are there. If there's something that involves a very low number of cases, for example, botulinum alert, we may just skim that visually. Or if it's something that falls into one, let's say, GI respiratory ILI, or a combination we do routinely, especially this time of year, all that stuff is scripted. So it's a matter of downloading the 30-day data set, downloading the alerts by day as a data set, and the script runs and generates the report. And then me parsing that out into an email to send to our local MOH, AMOH, and some of the contact people, for example, our infection control practitioner liaison with the hospitals and the outbreak managers would get all that information. And that takes about 20-25 minutes-ish, depending. Okay, I'm not sure. There's a couple questions that I might need some elaboration on. So I've had a question about what was done to get them out better during this time. So I think that's a follow-up to the PSA. That's part of the analysis of the actual response protocol to see what the time lags were. In this case, it was a matter of a couple days. Could we have sped that up or not? And what are the different algorithms, and what are the pros and cons of speeding something out or getting them out better, which might mean better information in the PSA itself. It might mean a more rapid response, and then balancing that about whether you're crying wolf. So if your threshold is, let's say, for a GI alert, you'd have to have a sustained alert from, let's say, more than 1 day of alerts from a single hospital, or you would need to see multiple hospitals alerting on a single day, or some other parameter of analysis, let's say a specific age group affected. These are all things we're working on in the response protocol to see, are these triggers useful? Are they too detailed for what we really want? And does it allow us to get better information and better interventions out in practice? So it's really a work in progress. And because we don't do it very often, thankfully, because we don't have a lot of huge outbreaks or anything that seem to be happening apart from the more or less routine ones, the PSA would probably only go out at the outset and may go out again to reinforce a message, for example. So that second PSA may not even be based on the alerts, but based on a sustained volume in the hospitals, even if the alerts extinguish, which they may well do, because the algorithm will incorporate newer and newer data as it progresses through time. So these are all questions that we have, and ones that we've looked at less formally than I would like, but because we haven't had a lot of instances of PSAs or other interventions go out, we don't have a lot to really critically analyze it. Okay. So there is a question here about there's a question about whether there was a way that that the public can share. Sorry, I'm just have to. The scrolling here is sort of cut off the tail end of. Okay, unfortunately, the system has cut this off slightly, so I'm just trying to see if I can expand the window. But it looks like the question is with regards to.
Do you want me to read it for you?
Yeah, if you could.
So the question was if there's a way of getting the public to share alerts with public health, rather than public health sharing with the public providing information to public health.
So the public would share things about their own disease state? Is that the idea?
Yeah.
Okay. Yeah, that's a possibility. I know that there's been talk of applications that would do just that. So like a smartphone application that would say, okay, I'm feeling this. You would get that information up, and it's sort of what you're doing is using that as a first point. So if you look at the example, remember the examples I gave. The question would be a little bit about how severe is it and what's going on with you, but it would be an interesting point. It's not something that we've formally sort of considered undertaking. Probably the nearest thing we would have to right now is telehealth, where people would call in. We also, in the midst of H1N1, did analysis on our phone line calls. So if people were phoning in and saying, "I feel sick, what should I do?" That would be that was another thing we did. We don't do that systematically, though. The other piece is we also had a website up that allowed people to input their child's symptoms, and it would make a recommendation similar to what they would get if they'd called the public health information line about what an appropriate care-seeking behavior may be. And that would be another way of people can actively provide their information. Perhaps less specifically than what was suggested here, but it's certainly interesting to think about, and the same questions would apply. How do you externally validate this sort of thing?
Do you want me to read you the next one?
I think I'm okay. It was just that one. Okay, there's somebody telling me to read the question. Data sources for telehealth alert system. How are calls coded into syndromes for that data? Essentially what happens.
So can you repeat the question?
Yeah, so sorry, I'm just reading it out loud, but the telehealth alert system is one that's conducted by, the question was, how do you code calls into the telehealth alert system? The telehealth alert system is run by the Ministry of Health and Long-Term Care. I've asked that question a couple times, and there may be somebody on the line who can post a quick response. But essentially the calls are coded, and I don't have details on how that works exactly. But it's probably not dissimilar to what we get even at our local phone line, where the public health nurse on the line is requested to use a specific code if the question is about information about a particular disease, or if the person says, I'm symptomatic, what should I do? And that's how the system works. I don't know the particulars of whether people can be coded into multiple syndromes, or if there's a push point where a person would, say, drop into a respiratory or a GI or something else, because even with the alert that I showed, ILI respiratory is combined. So I'm not all that sure how the system works in terms of that case classification. Okay, so that looks like there's a follow-up comment, which isn't really a question, so I'll skip that one. The question about why was RODS used, that predated my involvement, and I really can't honestly speak to it about what the selection of the basis of that particular system was. So I can try to get that answer for you if you want to email me, but unfortunately I don't have it at my fingertips because it predated my involvement in the asset system. just going to take a skim through to see if I've missed anything. And if it looks like I've...
There's one last
Pardon me,
question.
do I?
Yes, how many years of historical data was submitted by the hospitals, and will the 2009 data skew the building of ILI respiratory syndrome baseline?
We have data going back to, I believe, fall of 2007. Sticks in my head. Unfortunately, I didn't double check that before I came in, although I should have expected the question. So we've got probably about 3.5 to 4 years of data right now. Actually, no, I think it's 2008. Pardon me. So about 3 years of data. And will the H1N1 experience skew it? Absolutely, it will. And that's one of the challenges in the system itself when you get an aberrant year. So whether that had been H1N1 or even a flu flavor that wasn't covered by the vaccination, these are all sort of backgrounders that you have to consider. And really, the only way to deal with that is to accrue more and more data as we go. You know, some of the outbreak related information or the cases we see with outbreaks in long-term care, for example, may follow a cyclical pattern. So we've got about 3 years worth of data that sticks in my head, and we really don't have, I guess this is a follow-up to the question that happened earlier a little bit about how do you tell if you're really having a bad year or not. But the pandemic H1N1 has really obscured that, and it's almost impossible to parse out because we're not dealing with final diagnosis here. I guess this is the only answer I can give at this point.